an overview of all of the different work that's going on at the department and in partnership with many of you all on the Healthy Opportunities, which is our work on the social determinants of health. It's 6 main priorities, and a lot of it intersects with Medicaid transformation and is very much in alignment with what was just presented on, but much of it is for the entire population, not just our Medicaid population. So just to keep in mind. And probably can skip some of this for the folks in this room, but just the background of our strategy on truly buying health and not just health care. And currently, when we spend the majority of the healthcare dollars on direct medical care, but know that so much of what drives health is in other sectors. So just thinking about how we can better buy health by investing in some of the other areas as well. Again, some of you might be familiar, and Kelly mentioned it as well in her presentation, but we're focusing on these social determinants of health can mean 1,001 things. And should continue to, but just for the sake of prioritizing, we are focused on these 5 domains initially, and our screening tool is really focused on the first 4 of food security, housing stability, transportation, and interpersonal safety. And our opportunities for health work is really around 6 main initiatives. And I'll speak to all of these. The first is, and I don't know if I missed the presentation earlier. I don't know if this was mentioned. Is Dr. Cole still here? No, great. Well, we stole this idea from her and her partnership with Novant and others. They did this hotspot map first, I believe with the same domains to show the geographic health and economic disparities across their catchment area in that part of the state. The New Hanover also did something similar in their area, and we decided to map the whole thing statewide, which has been really useful for planning purposes. This is what it looks like. Have folks seen this yet? And say yes. So this is the map, and we've seen already, this is an example of the new kind of New Hanover region, southeast North Carolina, and they realized that right in their area they had many food deserts and put a grocery store in one of those areas. New Hanover, Atrium and Novant are using the map that they created for planning for how they prioritize resources and invest resources in the community too. So we've seen a lot of great work being done using, we all know where the areas of immense poverty are in our state and where there are capacity constraints. A lot of this we already know, but I think it's been helpful in directing resources so far. And we continue to use it, and we're making improvements on this map over time. The second key infrastructure piece is just a focus on our workforce. Going a little bit out of order if you remember that other slide, but so this is just our work in partnership with the Office of Rural Health. I know Maggie is or was here, and they're really leading this work with the Division of Public Health at the department on how we develop, train our workforce, particularly around community health workers, but all of the other parts of an integrated care team, which is so important for all of this work to be successful. The next piece, and this was already touched on by Kelly, we're creating with the help of our technical advisory group, which folks in this room might have been, I know that some folks in this room might have been a part of that group to create a standardized screening tool. There are already many screening tools across the state that folks are using, Prepare and others, and we wanted to create kind of a statewide screening tool for the sake of data creation and for those who haven't already adopted a screening tool to use. This was released this is its current state. It was released for public comment back in April. We received a ton of great comments and made a lot of changes based off all of those, and have been field testing it in 18 clinic sites for the past few months, and we'll get all of that data back. And we're reviewing that now to see if we have to make any more changes based on just making sure people are understanding it, and that workflow issues and some other changes. So working on that now. At the launch of managed care, this will be part of the care needs assessment that Kelly was talking about, that folks will be screened with when they enroll in a plan. So we also often get the question of, when you screen, you need to navigate folks to resources, and what is the way that is being done. So we are working on creating the North Carolina Resource Platform, and in partnership with the Foundation for Health Leadership and Innovation. I know we've talked to a number of you, or folks on our team have talked to a number of you about this platform and have given you demos, so apologies if this is repetitive for some. I'm happy to speak further, because I'm going to do not as great a job at explaining it as some of our vendors and our implementation team, so happy to talk to you more after about any additional demos or information about this platform. But when we were first organizing this work, had a series of stakeholder interviews, and folks kept coming back to the idea that there were so many barriers for folks to work across the healthcare space and the human service organization space. And what if there was a platform or a technology software platform that could really provide this infrastructure, which led to us thinking through and talking to a number of vendors and partners about how we build a statewide platform and why. We have been talking to other states about how not having unified platforms was difficult on the CBOs and providers, because they would be onboarded onto a number of different platforms. So it led us to create this statewide platform. The Foundation for Health Leadership and Innovation put out an RFP to choose the vendor back in May. Sorry, the months are all a little bit rolling together. Back in May, and chose the vendor, I believe, in August. That platform is built and ready to go, and we're hoping to be onboarding health systems over the coming couple years, hoping to be statewide within 2 years. So that was a lot of intro without actually explaining what it is for those of you who are less familiar. And I already spoke to a lot of these points, but we're hoping to build one statewide shared public utility that is where it is being funded through philanthropy and private dollars through the Foundation for Health Leadership and Innovation for the first 5 years. It's open to all communities, providers, care management, human service organizations, everyone. We're hoping to create a coordinated network to truly knit together our healthcare and community service organizations to create truly a health system. And I already spoke to some of the reasons why collaboration and statewide consistency is important, so won't repeat. This is the main functionalities of what we envision for the platform. It's more than just a resource database, but it will have those components. Similar to building off of what NC 211 is now, they are a vendor and partner in all of this in the United Way. So we will build off their amazing 18,000 resource database that they have in the state and their call center. So there will be a public-facing website that folks can access, and the call center, it will have a robust set of resources. We're also building, in addition to what they already have, a resource repository, which will allow through APIs the sharing of resource data across different resource databases. So we know that there isn't just the 211 database. A lot of other communities, local health departments, as part of their accreditation, have to keep their own resource lists. Others have them as well. So allowing the ability to share our resource data with community and vice versa, to really have the most updated list of the most updated list of resources and community-based organizations as possible. So really excited about that, and that's the only piece of all of this that is kind of in the process of being built and will be built out over the next year. So a piece of that is done now, and we're able to onboard without it but we're still building some of that API and sharing capability now. The second piece, and what's a little bit more novel and new to the state, although a lot of people are already using different vendors and have been thinking about this for a while, is the referral platform component. This really allows users to, in the same way that you connect someone to a specialist and that they see that referral on the other end, you can do the same with a food pantry or other community resource. So actually sending that referral to the food bank, food pantry, they will be onboarded onto the same system, will receive that referral on their end, and will be able to, in the case of a food pantry, you don't really need to schedule an appointment, but in another type of resource, you might need to schedule an appointment or meet with the person, and then send that outcome back to the initiating provider. And that'll be more clear on some of the other slides, but the referral also doesn't need to be initiated by a healthcare provider. When someone comes to the food pantry and they realize they don't have a place to sleep that night, they could also then send a referral to a housing or homeless shelter provider. It allows the ability to track connections and have that closed loop referral in a way that right now when we do paper referrals or what 211 does now, we won't really know what the outcome of that referral is. So it'll be a chance to really get that closed loop referral. It also allows for a shared patient record. So there's some exceptions to this. Obviously, there's role-based access and a lot of security and privacy built-in features so that we can't see, obviously, all legal services, any referrals to a legal service or domestic violence shelter, all of that is definitely locked down. So other service providers can't see those referrals and those outcomes, but it will allow in some situations, the ability to see where that person has been to be able to really get a fuller picture of their needs. And then also, what's something that's really important, or the last 2 points maybe are really important, this flexible architecture with integration interface capabilities. We know that some folks are already using systems, and just making sure that we can be integrated with those, both EHRs and other care management software so that it fits better in a provider's workflow, but also other referral platforms in the case that someone is already using a different vendor, or on the CBO side, if they're using Salesforce or something like that, make sure that we can do those integrations so that it's well integrated and seamlessly fitting into their workflow as well. And then the last piece, I think, is probably the most important, that the majority of the cost for this platform is this last piece in the blue, the hands-on and in-person technical assistance to onboard all of our providers and all of our CBOs. So that's something that we're really committed to, and if folks don't know how to use it and what value add it is to their practice or their daily workflows or their patients or the people that they serve in the community, they're not gonna use this. Just who's in the network, I think I spoke to most of this already, and I spoke to this as well, but this is the concept that it's a no wrong door approach, so the client can, just seeing how clear it is, if you can actually see what I am seeing on my screen. Okay, so the person can talk to, you can insert care coordinator, you can, with anyone, they're a community health worker, they're a healthcare provider, they're someone at a DSS agency that they're working with. They can use the resource platform to direct them to a wide variety of services. And if they get to the housing provider, but they realize they have additional needs, they can initiate another referral to someone else, in this case, an employment provider. And I think I spoke to some of these points already, but this is kind of what one of the screens looks like. It means nothing because you can't really see. And again, happy to do a real demo on this because it's pretty complicated, and there are people who speak to it way better than I do. But just to some of the other major pieces of it, it has configurable screening. We'll be including the statewide screening tool that I mentioned earlier in this platform. But if you consistently do other types of screening, that can all be added and done in the same workflow, or in the same platform. The electronic referral management, just seamless referral to the right provider, no longer just making those calls or just printing out handouts, and the other ways people do this now. This is the point I was trying to make earlier about the custom care plans for each service that are attached to the referrals, so the receiving providers kind of get a head start. They already have some of the information filled out and know more about that person before they come in, so they know what types of things they might be eligible for, types of services. Bidirectional communication, so you get automatic notifications when any of the outcomes change or closed loop referral is completed. And you can also communicate with between health and human service providers in the platform. And of course you get the outcomes, and you can see the entire history of your patient through the portal. So that was the resource platform. Quickly moving into another component of building in the Healthy Opportunities work into all parts of Medicaid transformation. These are just examples of some of the things, as you might have seen in our very long RFP. You might have already seen all of these things or heard about all of these features, but as Kelly mentioned, you are now able to, even without being just high risk, high needs, get into care management if you have unmet social needs across 3 or more of our domains, or there are some other ways to get in as well. And also there will be requirements for the PHPs to screen all beneficiaries with the care needs screening, and then in year 2 they'll be required to use the resource platform to connect folks to resources. The quality strategy has withhold-based incentives for the screening and navigation to resource needs. There's flexibility in allowing health-related services to count as patient care in the numerator of the MLR. Also similar flexibilities in the use of in lieu of services and value-based payments. And in the future, thinking about how we can risk adjust based on social need as well, but don't necessarily have the data to be able to do that well currently. And as part of our Medicaid transformations, this is really the previous slide and then these slides are really the only pieces that are just for Medicaid only and related to the Medicaid transformation. But obviously this is approved as a part of our 1115 waiver, so this is just for our Medicaid population, our Healthy Opportunities pilots. So we asked CMS as part of our 1115 for a lot of flexibility on being able to use Medicaid dollars to actually pay for some of these social services that we know are so integral to health. So these pilots will test these evidence-based interventions to show that they will reduce costs and improve health by more intensely addressing each of our domains for eligible Medicaid beneficiaries. I'll talk about eligibility in one more slide, or maybe 2 or so. So this is what kind of the structure of the pilots will look like. We will choose all prepaid health plans in the region will be required to if they're, maybe I'm going out of order, I can come back to that. This might be an easier slide to go through. PHPs will be required to participate in if there's a pilot within the region that they're serving in. And maybe I should even go. Sorry, these are not my normal slides, so I very much apologize. I guess it doesn't say here. Anyway, we will do a formal RFP procurement for choosing our pilot regions. There will be 2 to 4 pilot regions, and regions are really loosely defined. I can send out, I don't know if folks have already seen our fact sheet about the pilots, which will be more clear, but I can send that out if that would be helpful. So there will be a formal RFP coming out next year that will help choose those pilot regions, and a pilot region will just be 2 or more counties that cross urban and rural areas. So all PHPs that are in a pilot region will have to participate. they will work with the lead pilot entity, which is what's in purple. And the lead pilot entity's main role is to create a network of human service organizations across all 4 domains, so that when a care manager would screen somebody for eligibility and for a resource need, they would work with the lead pilot entity to direct them to a human service provider who could deliver that service. So if they're food insecure, for example, they could work with or housing, unstable housing, they need permanent supportive housing, they would work with the lead pilot entity to find someone who could provide the permanent supportive housing resources in their region. So as an example, and I'll show more examples of what types of services we were approved for on a later slide. But that's generally how it works. It's mostly coming through the care managers, whether they live at the PHP or more likely at an AMH or a local health department in the case of pregnant women and others. So the care managers will really be taking the lead in identifying eligibility and working with the PHP to authorize those services. So the PHPs will receive the capped amount of funding for pilot services. We received authorization from CMS to spend up to $650 million. That's kind of outside of the traditional rates. So they'll receive a capped amount of funding for these pilot services. They'll make the final determination of pilot eligibility and service authorization kind of in the same way. They're managing the money in the same way they might traditional healthcare services. And they'll have the discretion to deny services within guardrails defined by the state. So there are probably incentives to direct, for example, these resources toward their highest need, highest cost folks. A huge piece of this is a focus on children, so some guardrails around focusing a certain percentage of dollars on children, for example. So that's what we mean by guardrails. PHPs will leverage the care managers to identify the eligible beneficiaries, assess and reassess every 3 months, assessments on whether they're getting, when they get the resources, are their resource needs met? If they're getting a medically tailored food box, for example, are they no longer food insecure? As a very base level, then also determining over time if their health outcomes are improving and costs in our evaluation. Referring beneficiaries and coordinating with human service organizations. We see the resource platform as a really important infrastructure to all of this working, and then they're tracking beneficiaries' progress over time. The lead pilot entity, as I mentioned, is developing and managing and providing technical assistance to their network of CBOs and social service agencies, which we're calling human service organizations, because just one more new acronym is necessary in all of this work. And then human service organizations will contract directly with the LPE and will deliver all of the services, and they will be paid by the LPE directly. So this is just more information on the functionalities and roles and responsibilities of the lead pilot entity. Already spoke to most of these things. One piece I'll speak to just again, providing technical assistance. Most human service organizations aren't used to being paid in a reimbursement way or used to tracking information in this way, so providing technical assistance to those who are used to mostly dealing with grant funding and other things. Also, we know that there are a lot of, there's working with human service organizations or others to build capacity in regions where there aren't permanent supportive housing resources, and how we can grow those. So they'll be doing a lot of that work as well, in addition to collecting and submitting data, which will be really important for our evaluation. There will be rapid cycle evaluation, so annual assessments, annual evaluation to make sure that to see if the services that we're providing are actually doing what we think that they'll do, and being able to add new ones or cut back on those that aren't working. So we'll be doing rapid cycle evaluation, and then also an end of the waiver of a summative evaluation on the overall pilots, with the hope of seeing that we have improved health outcomes and at least been cost neutral, and that we can roll this out statewide. This is to just the eligibility of who might be eligible for the pilots. It depends on, for adults, an example of an eligibility criteria is 2 or more chronic conditions. For pregnant women, there's a whole number of different eligibility criteria that are different. And children we have broken out into 0 through 3 and 0 through 21. There's a whole list in our STCs of all of the different things that could make one eligible. These are just examples of some of the conditions or health needs that might make one eligible. They also need to have one social risk. And these are the examples of some of the approved pilot services. I don't know. Yeah, I guess it's pretty large. These are some of the things. So in housing, tenancy support and sustaining services, for example, housing quality improvements, actually going in and ripping up carpet and putting in new carpet or air filters, those kind of things for asthma and other conditions. One-time housing payments, so first month's rent and security deposits, which is really exciting. That and the short-term post-hospitalization housing, which is up to 6 months, is really exciting because CMS has really never approved these kind of housing-related support, so really excited about that. Food, I think I mentioned in all my examples, these already, in transportation and interpersonal violence. We have in our SDCs, there's the very long lists of all the things that we were approved for, which you can find. And this is the process. In early 2019, we'll be putting out an RFI. A lot of this is really new. We'll have to create things like a fee schedule for food boxes and things like these things haven't really been done before. So we're seeking a lot of feedback from care managers and health systems and those who might be a lead pilot entity and those who human service organizations on how we should be thinking about the rest of our pilot design. We'll be incorporating all of that feedback into the RFP, which will go out in the summer of next year. We'll choose our LPEs and pilot regions by the end of next year. And then all of 2020 will be a capacity building year. The lead pilot entity getting ready to deliver these services in a new way and building their network and all the technical assistance to the HSOs. And then we'll actually begin service delivery in January of 2021 until the end of the waiver in October 31st of 2024. So that's really quick. And we're all feeling the pressure of designing these pilots back at the department, but that's the end of the presentation. So any questions?